One of the main motivations for the study was a gap. As the title suggests, we set out to determine the MEV 90, that is the minimum effective volume of 90% of patients, for the ultrasound-guided selective trunk block, in short, called as the SETB. Now, before that, what is SETB and why is this important for upper extremity surgery? So additionally, the supraclavicular brachial plexus block has been described as the spinal of the upper extremity, but in practice, it often falls short. The key reason is that the suprascapular nerve, which provides important innervation to the shoulder, can branch off anywhere between the level of the superior trunk and the supraclavicular fossa. So when we perform a supraclavicular brachial plexus block, there's a real chance of missing that nerve. Clinically, this becomes obvious in proximal humerus surgery, where the supraclavicular brachial plexus block alone is often not sufficient. Clinicians have tried combining interscalene with supraclavicular blocks to cover this gap, but that usually requires large volumes of local anesthetic. The selective trunk block, on the other hand, directly targets all three trunks of the brachial plexus. Since all the nerves that supply the upper extremity pass to the three trunks of the brachial plexus, by doing a selective trunk block, we can reliably anesthetize the whole upper extremity. Therefore, SETB theoretically becomes the true spinal of the upper extremity. So our goal was simple, that is to establish the MEV 90 for SETB so that we anesthetists can apply it more consistently and safely in clinical practice. A unique aspect of our study is the use of modified Narayana rule for the sequential up and down design. Now, in any dose finding study or quantal bioassay, there are two key components: how we decide the subsequent dose allocation and the target dose estimator. Traditional dose allocation methods like the Dixon mode design base the next dose entirely on the outcome of the most recent patient. That makes them less efficient and really only suitable for estimating median values, such as the MEV 50. The modified Narayana rule is different. It incorporates information from all previous patients treated at a particular dose, not just the last one. For example, let's say patient number 9 receives 21 mils. In Dixon mode method, the next dose would depend only on whether patient number 9's block succeeded or failed. But with modified Narayana rule, we also consider the outcomes of all earlier patients who received 21 mils. And those results collectively guide the next dose allocation. This richer use of data allows us to directly estimate non-median targets like MEV 90. The result is greater precision with smaller sample size, which is both ethically and practically important in anesthesia dose finding research. In other words, it's a methodological advancement that makes dose finding studies safer, more efficient, and more reliable. Our study estimated the MEV 90 of a 1:1 mixture of lidocaine with epinephrine and levobupivacaine to be about 24.7 mils. Now, it's important to note that this number cannot be directly compared with dose finding studies of other brachial plexus blocks because those studies differ in the local anesthetic used, in the methodology of dose allocation, and in the clinical criteria chosen to define a successful block. That said, our result is well within the range that we routinely use in clinical practice. And importantly, at this dose, the time to achieve complete anesthesia was only about 15 minutes, which is clinically encouraging. The practical implication is clear. With SETB, we can provide reliable and consistent surgical anesthesia across the entire upper extremity, including the shoulder, using a standard volume of around 25 mils. For practical purpose, this can be divided approximately as 7, 8, and 10 mils for the upper, middle, and lower trunks, respectively. Of course, safety is central. We found that even at the lowest study volume of 21 mils, the incidence of hemidiaphragmatic paralysis was very high. That is about 85%. So while SETB is highly effective, it is certainly not a diaphragmatic or diaphragm sparing technique. And this is not surprising because even very small volumes, as low as 5 mils above the supraclavicular fossa, have been shown not to spare the phrenic nerve. This makes patient selection critical. In those with normal respiratory function, selective trunk block can serve as an all-purpose block for upper extremity surgery. But in patients with compromised pulmonary reserve, it may not be safe, and in such cases, alternative diaphragm sparing techniques such as the costoclavicular brachial plexus block should be considered. To conclude, our study showed that the MEV 90 for selective trunk block is 24.7 mils. At this dose, we were able to achieve complete anesthesia of the upper extremity within about 15 minutes. However, we also observed high incidence of hemidiaphragmatic paresis, around 85%. We hope this work not only informs clinical practice by defining a standard volume for ICTB, but also highlights the value of advanced methodologies like the modified Narayana rule in anesthesia dose finding research.